Assalamu alaikum warahmatullahi wabarakatuh. Today is with us Dr. Ayesha Tabinda. She is a Pharm.D Doctor of Pharmacy from Karachi University. She is B Pharm in 2007 and Pharm.D in 2012. She has passed her BCPS in 2020. She is working as a hospital pharmacist in Sheikh Khalifa Medical City, Abu Dhabi. Previously, she has worked with the Healthline Medical Center as well. She has worked as an oncology pharmacist as well in the past. Today, she will present on the men and women health for the BCPS Cohort II. I would like Dr. Aisha to please start your lecture today. Assalamu alaikum, Dr. Aisha.
Welcome, Sam. Thank you for
Yes,
introduction.
Dr. Aisha, the stage is for you.
Okay. So thank you for the introduction and the chapter which is I'm covering today for BCPS preparatory classes is men and women health, and they are different topics in it, including menopausal therapy, and we will take overview of osteoporosis and some complication in pregnancy, including preterm labor, induction of labor.
Dr. Aisha, can you be little loud?
Okay. Okay. So you can hear me now properly?
Yeah, perfect.
Now it's fine. Okay. So different topics I will cover in this chapter, and it includes like hormonal therapy and some complication in pregnancy, overview of osteoporosis, and lastly we will discuss some sexually transmitted infections. So we will start now. This is disclaimer that I'm not receiving any financial or commercial funding for support of today's session. Okay, first topic here is menopause or hormonal therapy. So menopause can be defined as cessation of menstrual period for 1 year or loss of ovarian follicular function. Average age for menopause is 52 years, but it can vary from 40 to 58 years. Common symptoms for menopause are divided as like vasomotor symptoms, and there is GSM, genitourinary syndrome of menopause. Vasomotor symptoms, commonly known as hot flushes, where women experience increase in skin temperature, nausea, dizziness, headache, palpitation, diaphoresis, and night sweats. And these symptoms can drastically affect quality of life. And actually, vasomotor symptoms are main reason for hormonal therapy in postmenopausal women. Next is another kind of symptoms is genitourinary syndrome of menopause, and it include both vaginal and urinary symptoms. And it include vulvovaginal atrophy, which can lead to pruritus and pain, dyspareunia, and due to vaginal pH changes, the woman can experience recurrent UTIs, and thinning of urethra and bladder lining can cause recurrent episodes of urinary frequency, urgency, or dysuria. Benefits and risk of estrogen and progesterone. So, estrogen and progesterone are actually the main hormone which are regulating women menstrual cycle. In menopause, the symptoms appear because of absence of these two hormones or their very low concentration. The benefits when we are taking estrogen or progesterone exogenously are they can relieve from genitourinary atrophy, relief from vasomotor symptoms, reduction in osteoporosis, help improvement in insomnia by decreasing hot flushes, stabilize mood swings, and decreasing pain with sexual intercourse. Risk associated with estrogen is endometrial cancer, breast cancer, gallbladder effects, and these three main risks actually can be subsided by using progesterone in combination with estrogen. The other risks are bloating, headache, breast tenderness, VT, stroke risk. Stroke risk actually can be doubled with use of estrogen, so it's usually contraindicated if there is a stroke risk of inpatient. Progesterone benefit is actually decreased risk of estrogen-induced irregular bleeding, endometrial hyperplasia, and carcinoma. Risk associated with progesterone therapy is bloating, weight gain, irritability, depression, and they are all dose related, can be reversed. Treatment and management. Hormonal therapy for menopausal symptoms include estrogen and progesterone therapy, estrogen only therapy, and estrogen receptor agonist or antagonist, which we call as SERMs sometimes. There are FDA-approved indications for hormonal therapy are moderate to severe vasomotor symptoms, moderate to severe vulvovaginal atrophy of menopause, and here for vulvovaginal atrophy symptoms, recommended is to use of local hormonal therapy. We will not go to use for oral or systematic hormonal therapy as as possible as we can because of severe risk. Then prevention of postmenopausal osteoporosis, then hypoestrogenism caused by hypogonadism or premature ovarian failure. There are formulations in which hormones are available: oral, transdermal, vaginal, or local preparation. Oral and transdermal are usually used for treating vasomotor symptoms. They can cover some GSM if present concomitantly. Transdermal patches formulations are first-line formulation for women with moderate risk of CVD if hormonal therapy is needed. And vaginal and local preparation in general used for women with GSM. So usually it is sufficient to use local preparation for treating GSM symptoms. Risk assessment. Before starting any hormonal therapy, we will do some risk assessment to initiate any hormone. It can be initiated or it cannot. So, for example, for women who have high risk of ED and they are requesting hormonal therapy, if they are not contraindicated, we can go for non-oral route of hormonal therapy with lowest effective dose. And another one is women with high risk or have a history of breast cancer. We will not go for hormonal treatment. We will go for other treatment for symptomatic relief. For women with high risk of CVD, such as non-myocardial infarction or any abdominal aortic aneurysm, diabetes mellitus, or they have 10 years CVD risk is greater than 10%, we will not initiate hormonal therapy. We will go for non-hormonal treatment, which is recommended for symptomatic relief. Then women with moderate risk of CVD, transdermal estradiol is appropriate. With combination or without combination, depending on woman condition. Then these are the agents used for the management of menopausal symptoms. Hormonal therapy in estrogen, we have agents ethinyl estradiol, masterenol, DES, tibolone, sinestrol. Then estrogen and progesterone combination, estradiol, norethindrone. They are used for moderate to severe cases of menopausal symptoms. And estrogen and progesterone combinations are used for treating these symptoms where women have intact uterus. So this combination of progesterone with estrogen is actually decreasing the risk of developing endometrial cancers. Then other treatment option is SERM, ospemifene example, and it is indicated for for the treatment of moderate to severe dyspareunia caused by vulvovaginal atrophy of menopause. Second option, in SARM we have conjugated estrogen plus bazidoxifene, and indication is for severe vasomotor symptoms or prevention of osteoporosis. We have SSRIs for vasomotor symptoms in women where hormonal treatment is not recommended. Examples are paroxetine, fluoxetine, sertraline, venlafaxine. Other hormone products are DEA, androgen, phytoestrogen, magistral. Natural products, black cohosh is the example we can use for vasomotor symptoms, and it also helps in osteoporosis management. Others is clonidine, gabapentin, pregabalin. They are not FDA indicated but used to treat for some vasomotor symptoms. This is the case where GK is 51-year-old postmenopausal woman with severe hot flushes that have not resolved with venlafaxine 75 orally daily. She is otherwise healthy with no history of cancer and no surgical procedure. She is given conjugated estrogen orally daily, which treatment is best for JK. So here, option A and B is suggesting no other drug is needed. Estrogen alone is sufficient for hot flashes. Okay, so no other drug is needed. Estrogen should be discontinued as she should continue on venlafaxine. This option is wrong because estrogen alone is not sufficient because this patient has no surgical procedure. It means she has uterus intact. So estrogen alone is not recommended for such women. Then estrogen should be discontinued and should continue on venlafaxine. It's not correct also because she's experiencing symptoms even if she's using venlafaxine. So it means she needs some more treatment. Then we can add medroxyprogesterone acetate should be added to decrease risk of stroke. This option is wrong in terms because medroxyprogesterone is not added to decrease risk of stroke. It is added to decrease risk of endometrial cancer caused by estrogen. So in 4 options we have best option is D. So in this way you will solve if you have all the knowledge or all necessary points you are remembering, then you can solve the best possible answer in cases. Next topic here is osteoporosis. Osteoporosis is condition where individuals have porous bones, weakened bones, and usually osteoporosis have no symptoms or any other pain, and usually it is the suddenly discovered when you have sudden fractures. So bones are actually living tissue, living growing tissues. There are two parts of bone, inner spongy part and outer hard shell. In osteoporosis, what happens? The holes in the spongy bone become larger and porous. Because of this, they become weakened and there are chances of sudden fractures. And bones are responsible for absorbing or storing calcium and minerals. And whenever body is needing calcium, it breaks down and rebuilds itself. And this process is called remodeling. So what happened after age of 35? This remodeling process becomes slower and breakdown become faster. So the chances of gradual loss of bone mass. Diagnosis: WHO actually defines osteoporosis on basis of T-score, and T-score is obtained by DEXA. T-scores are actually measured in standard deviation, and they are the reflect of difference between your bone density and an average bone density of healthy young adult of your age. So this chart is useful in explaining different terms like if your standard deviation is lying or your t-score is lying in between +2 to -1, you have normal bone density. If t-score is lying -1 to -2.5, this condition is called osteopenia. And if t-score is at -2.5 or less, this condition is called osteoporosis. Osteoporosis risk factors. Major cause is decrease in estrogen level in menopausal women. So risk factors are early menopause before age 45 or prolonged menopausal amenorrhea. White Asian race, thin build, hyperthyroidism, or not having natural born child. Drugs which can cause or induce osteoporosis are anti-epileptic drugs, phenytoin, steroids, heparin, excessive levothyroxine, GnRH agonist, medium chemo, drugs for breast cancers, family history of osteoporosis, low calcium and vitamin D intake, sedentary lifestyle, cigarette smoking, previous fracture, history of falls. When to go for BMD testing. So all women who are 65 years old or older than that, or all men older than 70 are recommended to go for BMD testing. Then men lying between 50 to 69 years of age plus who have previous fracture or have risk factors such as delayed puberty, hypogonadism, hyperparathyroidism, chronic obstructive pulmonary disease. So they are on the drugs called like glucocorticoids, GnRH agonists, alcohol abuse, or smoking, or whatever other secondary causes of osteoporosis. So these men should go for PMD testing. All postmenopausal women with medical causes of bone loss. Then postmenopausal women who are younger than 65 with at least one of the following conditions, like previous fracture after menopause, which are other than skull, facial bone, ankle, finger, or toe, or they have low body weight, less than 127 pounds, or they have low BMI, less than 21 kg per meter square, or they have history of hip fracture in parents, or they are starting or taking long-term systemic glucocorticoids for 3 months or longer. When to initiate drug therapy. So if there is a hip or spine fracture, therapy should be initiated. Or if VNDT score is -2.5 or below at spine, hip, or femoral, if VMDT score is between -1 and -2.5 at femoral neck or spine, and then your probability of hip fracture is greater than 3% or equal to 3%, or the 10-year probability of major osteoporosis related fracture is 20% or greater, according to FREC system. Length of therapy is usually 5 years. Then these are the osteoporosis treatment options we have. Bisphosphonates are cornerstone for osteoporosis treatment. Members including alendronate, calcitronate, abandronate, zoledronic acid, etidronate. GI adverse effects are flatulence. Then these bisphosphonates should be avoided if the creatinine clearance is less than 30 ml per minute. Calcium and vitamin D we are using in osteoporosis treatment as supplements. And calcium doses for women who are less than 50 years old is recommended is 1000 milligram, and greater than 50 years 1200 milligram. For men 50 to 70 years 1000 milligram, for greater than 70 years 1200 milligram. Vitamin D, again, supplement which it actually promote calcium reabsorption. So doses for greater than 70 years old, 800 units. If less than 70 years old or younger, those should 600 units per day. The other treatment option is SARM. Example is reloxifene, and it's used in prevention and treatment of osteoporosis in postmenopausal women who are vertebral fractures. Contraindication is for using SARM is pregnancy, VTE history, or greater risk of VTE event occurring during first 4 months. Then conjugated estrogen and bazidoxifene. These are also used for prevention and treatment of osteoporosis in postmenopausal women. Contraindications are same for pregnancy, nursing, VTE history, hepatic impairment. Then next option is calcitonin. This is not first line to be used for treatment and prevention of osteoporosis and usually reserved for menopausal women of greater than 5 years. And there is a risk of malignancy, and this when it is started, it should be discussed with patient for all the benefits, and yes, it is FDA recommended. Okay. Then teriparatide, human parathyroid hormone analog. It's actually work by regulating intestinal calcium absorption and renal tubular calcium and phosphate reabsorption, and indicated for treatment of menopausal women with osteoporosis that have high risk of fracture, and increase it is useful to increase bone mass in men with primary and hypogonadal osteoporosis at high risk of fracture. Contraindication for using of any human parathyroid hormone is hypercalcemia, bone metastasis, and disorders that can cause women uh, that can cause to bone tumors such as Patch's disease. Denosumab for postmenopausal women with osteoporosis and for men and women with bone loss associated with prostate and breast cancer. There are safety issues for using denosumab, including possible opportunistic infection, hypocalcemia. So we should take vitamin D and calcium as supplement while using this. And patients with impaired renal functions are actually more likely to have hypocalcemia while using this drug. This abaloparatide is another parathyroid hormone analog. Again, the same function, how it is regulate bone metabolism by increasing intestinal calcium absorption and renal tubular calcium and phosphate reabsorption. It is usually reserved for postmenopausal women with osteoporosis that have high risk of fracture, that is greater than 3%, and with very low BMDP score, that is lower than -3, and a previous vertebral fracture. Patient test. So RK is a 71-year-old white woman, height 6'3" weight 64 kg with a history of rheumatoid arthritis, who smoke half pack a day. She is lactose intolerant, has minimal intake of dairy products. She is taking calcium 1200 per day in divided doses and vitamin D 600 daily orally. Calculated creatinine clearance is 60 to 70 ml per minute. Her BMDT score is -2.6 at hip and -2.1 at spine. Her Praxis score indicates she has 10-year probability of major osteoporotic fracture of 22% and her 10-year probability of hip fracture is 11%. Which statement best describe the current diagnosis of RK? Options are she has normal BMD of spine, she has low bone mass, osteopenia of the hip. So first is incorrect because she doesn't have normal BMD. She has minus values 2.6, 2.1. She has low bone mass, osteopenia of the hip. No, she has minus 2.64 at hip. She has osteoporosis of the hip. So this is the best option until now. D is she has severe osteoporosis of the spine. No, she doesn't have severe osteoporosis of spine because her T score at spine is minus 2.1. So till now C is the correct option because her T score at hip is minus 2.6, so we can call it osteoporosis of the hip. So next is which is the best therapy for RT? So she is taking what? She's taking calcium, vitamin D, and then her condition they express their T scores and FACT scores. So options are no further treatment is needed. Continue calcium, vitamin D daily, or then give abaloparatide 80 subcutaneously daily and continue calcium and vitamin D per day. Then give romosozumab 210 milligram sub-Q every month, continue calcium and increase vitamin D to 800. Then option D is give residronate 35 orally weekly, continue calcium 1200 and increase vitamin D internal 800 IU daily. So according to the options, first two options are correct. Incorrect because she needs treatment. Her T scores and her FACT scores is giving indication then treatment should be initiated. Then calcium dose is correct, but for vitamin D for this age of patient should be increased. So A and B are incorrect based on vitamin D doses also. Then C option we have is giving correct calcium and vitamin D doses, but romosozumab is not the first line treatment because patient creatinine clearance is fine. It's 60 to 70. And first line treatment for osteoporosis is bisphosphonate. So we have option of bisphosphonate in option B. And here calcium and vitamin D doses are also correct. So we will go for option B in this case. Case 2. MD is a 72-year-old white man with a history of hypertension who admits smoking one pack of cigarette per day and having a poor diet. He said that he walked on treadmill 30 minutes a day. His bone mineral density score is minus 2.1 at hip and minus 2.2 at the spine. His fracture history includes a fall at age 68 with an ankle fracture. His fracture risk assessment score 10-year major fracture probability is 14%, and his probability of hip fracture is 6.7%, which describe MP's condition. So he has low bone mass osteopenia of hip and spine. Okay, he has osteoporosis of the spine and low bone mass of the hip. He has osteoporosis of hip and spine, and he has normal BMD of hip and spine. So low bone mass. Here only option A is correct because hip and spine giving us T score values which is describing osteopenia condition. So he has no osteoporosis of spine. B, C are incorrect, and he doesn't have normal BMD of hip and spine, so D is also correct. Incorrect. So A is the best option in this case. Which treatment is best for MP? So he should take calcium 1200 milligram orally daily, vitamin D 800 unit orally daily, and androgen 70 milligram orally weekly. B option is 1200 calcium and vitamin D 600 and begin with during exercise. This option is wrong because he should take vitamin D 800 and his FACT score, we go to the previous slide is actually indicated 14% or 7%. So he should start any treatment for osteoporosis. So only weight bearing exercise is not enough for that patient. So B is incorrect. Take calcium 1200 daily, vitamin D 600 daily, and raloxifene 60 milligram orally daily. Again, vitamin D dose is incorrect here, so we will not go with this option. Take calcium 1200 milligram orally daily, vitamin D 400 units orally daily, and niacin 35 milligram orally weekly, and begin weight bearing exercise. Here, niacin is bisphosphonate, but again, vitamin D dose is incorrect. So, until now, option A is correct. There is a bisphosphonate treatment here. Vitamin D and calcium doses are correct. So, best option here is A. Now, another topic is complication in pregnancy. So, during pregnancy, women experience different symptoms like morning sickness, heartburn, constipation, hemorrhage, headache. For all these symptoms, we usually treat mildly. We go only for symptoms, really will not use any extraordinary treatment. So another condition which can cause complication for pregnancy is the coagulation disorder. Care treatment should be continued even after throughout the pregnancy and even after postpartum. So if in pregnancy if there is a coagulation disorder, we should avoid warfarin, and we can only use low molecular weight heparin or unfractionated heparin. So for coagulation disorder, if patient is on any heparin, we should consider discontinue of therapy if if she is taking any prophylactic doses before 12 to 24 hours of vaginal or cesarean delivery. If she is on treatment doses, we should consider discontinuation of therapy before 24 to 36 hours of delivery. Then there is a case that a 29-year-old woman, height 65 inches, weight 63, has a history of two deep vein thrombosis, but is otherwise healthy, and she is seeking to become pregnant. She is currently taking warfarin 3 milligram orally daily. Which regime is the best recommendation for this patient? So she has DVT and she has treatment warfarin, but she is seeking to become pregnant. So warfarin should be stopped. Options are continue current warfarin dose to prevent clot during pregnancy, wrong. Continue warfarin therapy but increase dose to prevent clot during pregnancy is also wrong. Warfarin is not an option during pregnancy or the people who are seeking to become pregnant. So discontinue warfarin, start enoxaparin subcu daily until pregnant and continue throughout the pregnancy. So this is the best option till now. Last option is discontinue warfarin, start heparin subcu every 8 hours daily until 12 weeks pregnant and then initiate warfarin. So from our information, we will continue the heparin or enoxaparin or any low molecular weight heparin throughout the pregnancy, even after 6 weeks of postpartum. There is no option of starting or initiating warfarin again during pregnancy. So D is incorrect. So C is the best option in this case. There is gestational diabetes, another complication in pregnancy. There are the two diagnostic criteria, two-step approach for oral glucose test and one-step approach for oral glucose test. In this Two-step approach, we give 100 gram of glucose and we screen every hour for 3 hours. And if values are greater than or equal to at 2 or more points, you will consider as gestational diabetes mellitus. And in one-step approach, we will give 75 gram, we will monitor for 2 hours, and we again, if 2 or more points, um, what values are equal or greater than the chart available here, we will consider it as gestational diabetes mellitus. So for treatment, first line treatment is insulin, and second line is sulfonylurea. Metformin is still under investigation, and there is a risk associated for with metformin is of risk of premature birth. So insulin is actually the first line treatment for this condition. Then pregnancy-induced hypertension. In gestational hypertension, we can define as if high blood pressure experienced after the 20 weeks of gestation period. And if before 20 weeks, patient is experienced hypertension, then we will not consider it as gestational. Okay. The other condition is preeclampsia. And in this condition, patient is experiencing hypertension plus proteinuria, that is 30 milligram or more every 24 hours. Other features of preeclampsia are thrombocytopenia, impaired liver function like increased level of liver function enzymes to twice to the normal, or severe right upper quadrant pain or epigastric pain which is refractory to any medicine, and new development of renal insufficiency, that is serum creatinine is greater than 1.1, or doubling of the serum creatinine without any evidence of renal disease, pulmonary edema, new development of cerebral or visual changes. Eclampsia included tonic-clonic seizures, and chronic hypertension with superimposed eclampsia, in which there is a new onset of proteinuria after 20 weeks, and this is sudden 2 to 3-fold increase in proteinuria, and sudden increase in blood pressure, then increase in liver function enzymes, thrombocytopenia. Preventions of preeclampsia, it's evident that if we start aspirin in the beginning of first trimester, there is evidence of lowering of preeclampsia, where we are starting aspirin from 11 to 14 weeks of gestation till 36 weeks. So prophylactically aspirin can be used. Then for treatment options are like included like delivery, if woman is at full term. If it is not at term, having a bed rest and monitor blood pressure carefully. Then severe preeclamptic condition, we go for parenteral magnesium sulfate to prevent seizures. Then labetalol, methyl-dopa, nicodipine are first-line therapies. And parenteral antihypertensive include hydralazine and labetalol. Medication which should be avoided during pregnancy are angiotensin-converting enzyme inhibitor and ARB renin inhibitors and mineralocorticoid receptor antagonist. Preterm labor. So term labor is 37 to 40 weeks. If uterine contraction with cervical changes appears before week of 37, we will define it as preterm labor. Non-pharmacological treatment are bed rest, hydration, and sedation. And we can give prophylactically hydroxyprogesterone if patient has history of preterm labor of 16 to 36 weeks. And This should be IM 25 to 50 microgram IM every week from 16 to 36 weeks of gestation. Then tocolytic agents can be used to inhibit uterine contraction, especially if cervix is dilated less than 4 centimeters and membranes are intact. So agents includes beta agonists, cervically. Magnesium sulfate is actually drug of choice in diabetes mellitus for anticonvulsant in preeclampsia, and calcium channel blocker, nifedipine, verapamil. Induction of labor. There are conditions where, due to the complication in pregnancy, such as maternal infection, uterine bleeding, preeclampsia or eclampsia, diabetes mellitus, macrosomia, maternal renal insufficiency, or premature rupture of membranes after week 36. Uh, so induction of labor is needed. So inducing agents for labor are oxytocin, this is drug of choice available as IV. Ergot alkaloids are actually not used in late pregnancy or to induce full-term pregnancy. They are used to terminate early pregnancies, and they have to decrease postpartum or post-abortion bleeding. They are available as oral and parenteral. Prostaglandins, we have dinoprostone, misoprostol. They are available both orally and vaginally, while dinoprostone only vaginal gel or insert. Case is Assie is a 28-year-old woman who would like to get pregnant soon. Her medical history include hypertension and allergy. Her medication include lisinopril, nasal saline spray, and folic acid. Which option is best to treat her hypertension while she is pregnant or trying to conceive? Options are continue lisinopril at hydrochlorothiazide. So we come to know that lisinopril or ACE inhibitor is not should not be used. It should be avoided in pregnancy. So option A is incorrect. Discontinue lisinopril and all other medication. She really need the medicine, so we cannot go with option B. Discontinue lisinopril and start labetalol. This is best option so far. Continue lisinopril and agapinolol. So D is not the correct option. So we will go for C in this case. Overview of contraception. There are situations where patient has to go for contraception methods, and the factors where which are which should be considered while selecting any contraception method are effectiveness, or why it is needed to use contraception, adherence, and age. Age may affect adherence or any adverse effects. So cost and concomitant use of drugs, health status and habits. Methods of birth control include abstinence, male or female sterilization, natural family planning, spermicide. Barrier method include diaphragm, cervical cap, condom, female condom, sponge, hormonal contraception. Then combined oral contraceptive include combined oral contraceptive pills, transdermal patches, vaginal rings, progestin only, have progestin only pill, progestin only injectable, implanted rod. Then we have intrauterine devices, intrauterine system, copper IUD, progestin containing IUD or IOS. So in combined oral contraceptive, we have different formulations: pills, transdermal patches, vaginal rings. Pills have two types, estrogen and progesterone combined. Here, estrogen works by giving feedback to pituitary and inhibiting FSH and ovulation and causing an ovulation cycle. Then other effect of using this pill is Actually, they increase sex hormone binding protein, which is produced by liver, and it binds with the androgen, result in decrease in hormonal mediated acne. So for this effect, these pills can be used to treat acne and unwanted facial hair and hirsutism in women. Then progestin pills, including nortrindrone acetate, equinodiol diacetate, norgestrol, levonorgestrol. They work by sending negative feedback to pituitary and inhibit ovulation. They cause thinning of uterus lining. And the side effect is endometrial atrophy. Contraindication to use of combined oral contraceptives. If they are contraindicated of less than 21 days of postpartum if there is no DVT risk involved. If there is a DVT risk involved less than 42 days postpartum, you cannot use. Stroke, current breast cancer, migraine with 35 years of age, high blood pressure, cardiovascular risk, and smokers of greater than 35 years of age. There are management of adverse effects. So there are adverse effects of using the contraceptive pills, and before switching to any other contraceptive method, we will try to use any of the method at least for 3 months. This is called adherence. So adverse effects are breakthrough bleeding, nausea, acne. So again, it is explaining this point that you should try product for at least 3 months before considering switching. So breakthrough bleeding is early in cycle, that is 1 to 10 days. Choose product with high estrogenic property if you are switching to any other product. If bleeding is occurring late in cycle, that is 10 to 28 days, you will choose other product which has high progesteronic activity. Then nausea, we will again try to continue for 3 months. Usually nausea is subsided. It is because of estrogenic activity. Acne. Acne is usually due to androgenic activity of progesterone. So if you are considering switching, you will select a product which has less androgenic activity or high estrogenic activity. Serious adverse effects are abdominal pain, chest pain, headache, eye problems, severe leg pain. So abdominal pain can be a signal for liver problem or gallbladder problem. Chest pain, shortness of breath, coughing up blood could be signal of myocardial infarction or blood clot in lungs. Headache could be a signal of stroke, blood clot, eye problem, blurred vision, flashing lights, blindness could be signal of optic neuritis or stroke or clots. And severe leg pain with or without swelling could be signal of DVT. Here is the case again. 22-year-old woman started taking Nitrate 4 months ago for contraception. 4 months ago, so she actually passes the period of 3 months for adherence. She has breakthrough bleeding at the start of her active phase that lasts a few days before resolving. Physician wants to change to oral contraceptive. Which oral contraceptive on her formulary is best for the physician to prescribe? So this is the chart available contraceptive in formulary with estrogenic property and progesteronic and androgenic property details. So options we have: continue taking nitrate for another 3 months. It's we can switch because she already take nitrate for 4 months, so A is not considered now. Change to relaxin, change to losartan, change to lesina. So here is relaxin because she experienced breakthrough bleeding in the start of her cycle. So we will consider switching to any agent which has high estrogenic property. Here in the chart, we cannot see any high estrogenic. We have all low. Only one is intermediate, and this could be the best option for now. So we will go for refluxing, that is option B. Transdermal patches for oral contraceptive pills, they are not suitable for patients with BMI greater than 35 or who are weighing greater than 90 kg. And we have vaginal rings, and they should not be removed even during intercourse. Progestin only contraceptive. They are used for the patient who cannot tolerate combined oral hormonal therapy, like they have condition, current current myocardial infarction, stroke, DVT, CVT. They have atrial fibrillation, high blood pressure, smoker, age 35 or older, benign malignant liver tumor, history of cholestasis because of estrogen-containing products, migraine headache with neurologic impairment or aura, retinopathy or neuropathy because of diabetes, surgery within the past 4 weeks, and in breastfeeding it's preferable to take progesterone. So how progesterone pills work? They achieve cervical nipple, prevent sperm movement, can uterus lining, and they suppresses mid-cycle takeoff, LH and FSH, inhibit ovulation. Contraindication of using progesterone only pills is suspected pregnancy or active hepatitis. Patient has inability to absorb sex steroids from GI tract, that is active colitis, and if the person is taking medication that increase hepatic clearance, like KIP inducers. Only medroxyprogesterone acetate is okay to use with KIP inducers. Progesterone can be started on day 1 of the period, first day of the period, and there is no hormone-free days with progesterone. You can continue using pills. But when we are using progesterone only pills, we should use at the same time every day. And if there is a missed dose, if there is a like if time is greater than 3 hours of the time we are selecting every day, if it is past than 3 hours, we will consider as the missed dose, and we should go for backup method for 48 hours. Disadvantages of using progesterone only pills, progesterone related side effects like weight gain, acne, irregular masses, and adherence because short time window of missed dose. We have injections, Depo-Provera injection, and frequency to use for Depo-Provera is every 11 to 13 weeks. So 11 to 13 weeks is the window of using this Depo-Provera injection. Box warning for Depo-Provera is loss of bone, and especially in women who are taking this for at least 5 years, they have significant reduce of BMD of lumbar spine. And if this is initiated before age of 20 and after 15 years of use, the BMD can be reduced, and we should consider this fact before going for Depo-Provera injection. Then all women who are on the PMA should be taking sufficient calcium and exercise regularly. This is because the same condition that there are chances of loss of bone by using this injection. Patient should come back for the next injection between 11 to 13 weeks, and if more than 13 weeks pass, we will consider it as missed dose, and we should go for backup method. If we are ever changing from Depo-Provera injection to another method, we should start new method when next injection is due. And for Depo-Provera, there is a delay of fertility, return to fertility for up to 18 months. So it should be used with caution in women greater than 35 years or who have interest in future conception. Then Depo subcutaneously. It has same information related to uh, this Depo-Provera injection, but in addition, it has FDA indication for endometriosis. Backup methods with emergency contraceptions are condom plus spermicide, diaphragm, non-intercourse for 7 days. And we have intrauterine devices and intrauterine systems. They are usually used to prevent pregnancy long term. So if women having heavy menses and they are seeking pregnancy protection for 1 to 2 years, levonorgestrel intrauterine system is best choice for this condition. Contraindication to use of intrauterine devices or specific to copper IUD are pregnancy, women with current or recent sexually transmitted infection within 3 months, or women at risk of sexually transmitted infection who have uterus less than 6 cm or greater than 9 cm, undiagnosed or abnormal vaginal bleeding, active cervicitis or active pelvic infection, non-symptomatic actinomycosis, or recent endometriosis like past 3 months. Then we have patient case. LM is 37-year-old woman, height 67 inches, weight 95 kg, states that she is getting married soon and wants to begin contraception for now. However, she would like to have children in a year or so. Her medical history includes hypertension of 2 years and gastroesophageal reflux disease. She drinks 2 glasses of wine a week, smokes half pack of cigarette a day. Her medication includes hydrochlorothiazide, 25 mg orally daily, amlodipine 5 mg, benzapril 20 mg orally daily, omeprazole 20 mg orally daily, and occasional ibuprofen. Which contraceptive product is best to recommend for LM? Transdermal contraceptive patch. It is not recommended because she is obese. Her weight is 95 kg and transdermal contraceptive patches are not suitable for obese patients. Oral tablet ethinyl estradiol drospirenone. Because she is hypertensive, we will not go for any product containing estrogen. And oral tablet nortrindrone and DPM injection are 2 options. Here, DPM injection can be excluded because she would like to have children in a year or so. So with these injections, return to fertility will take 18 months or more. And she is 37-year-old already. So DPMA is not good choice here for her. So option C is best for now. Oral tablet nortrindrone. It is for all her conditions. This is the best choice. Then we have emergency contraceptive. Examples are EST, has high estrogenic activity, progesterone only. It's not preferred with the BMI 26 or weight greater than 75 kg. Uripristil acetate, not recommended for BMI greater than 36. Then copper IUD, used for BMI greater than 35, but it requires office visit. Then misoprostol is also need clinic visit, office visit. Then in fertility medicines, we have options of clomiphene, SARM, which is first line agent, and but it has risk associated with risk of multiple births. Metformin is sometimes used in combination with clomid, and it works by decreasing hyperinsulinemia, cause increased insulin sensitivity, thus reducing circulating androgens and help in weight reduction. So there are better chances of ovulation. Then HMG, human menopausal gonadotropin, menopause. We give it from 2 to 3 till 7 to 10 days for 2 to 3 cycles and then determine follicular development by estradiol levels. It can cause muscle aches and flu-like symptoms. GnRH analogs used to treat endometriosis. This is specifically not used for fertility and it can cause osteoporosis. Aromatase inhibitors, Femara, off-label use here for as infertility medicine, less risk of multiple births associated with it, and increased GnRH and gonadotropin and help in induce of ovulation. Other products which are used for treating infertility is progesterone. It actually used in luteal phase for support for patients with frequent miscarriages. Bromocriptine actually decreases prolactin and help in infertility. Sildenafil aids in increase of thickness of uterus lining. Guanfacine may help cervical mucus to aid in conception. And aspirin can be used before any fertility procedure for uterine blood flow and decrease risk of ovarian hyperstimulation syndrome. Last topic is sexually transmitted infections. So first is syphilis. Symptoms including syphilis is development of pancreas. These are non-pain ulcers in genitals. Diagnosis is usually based on CSF WBC count or reactive CSF VDRL. Management include like for primary syphilis, which is after 21 days of exposure, treatment is benzathine penicillin G, 2.4 million unit IM in a single dose. If there is a penicillin allergy, we will go for doxycycline and tetracycline for 2 weeks. Then there is a secondary syphilis, which is considered when there is a 4 to 10 weeks exposure time. Treatment is benzathine penicillin G, 2.4 million unit IM in a single dose. If there is a penicillin allergy, doxycycline or tetracycline can be used for 28 days. Then there is late latent syphilis. Treatment is again benzathine penicillin G, 2.4 million units IM every week for 3 weeks. If there is a penicillin allergy, doxycycline or tetracycline can be used for 4 weeks. Then there is a tertiary syphilis, includes infectious granulomas and cardiovascular effects such as aortic insufficiency and aortitis. Treatment is benzathine penicillin G, again 2.4 million units IM every week for 3 weeks. And if there is a penicillin allergy, treat in consultation with an infectious disease specialist. Then we reach to neurosyphilis. And treatment for neurosyphilis is aqueous crystalline penicillin G, 3 to 4 million unit IV every 4 hours or continuous infusion, total of 18 to 24 million units per day for 10 to 14 days. If there is a penicillin allergy, we can use ceftriaxone 2 gram per day IM or IV for 10 to 14 days. All patients should be desensitized and give penicillin. Second sexually transmitted infection is herpes simplex virus. Important point to remember for herpes simplex virus that treatment for this virus can partly control symptoms but does not affect the risk, frequency, and severity of recurrence after it is discontinued. So, actually, after primary infection, the virus is latent in sacral dorsal root ganglia. Symptoms are itching, genital burning, vesicle formation, and ulcers. And treatment include acyclovir, famciclovir, valsaclovir. For patients who are having 6 or more episodes of infection within the year, daily suppressive treatment is recommended, which include either twice daily regimen or once daily regimen. And in severe cases, patients should be hospitalized and treatment should be acyclovir IV every 8 hours for 2 to 7 days, following oral antiviral therapy for at least 10 days of total therapy. Then herpes encephalitis. Symptoms include headache, fever, speech disorders, and behavioral changes, focal seizures, and cerebrospinal fluid analysis shows moderate pleocytosis and normal glucose and moderately elevated protein. Therapy include IV acyclovir for 21 days. Clinical case is DH is a 21-year-old woman who presents to clinic with genital itching and vesicle on her vulva. She is sexually active with one partner who has a history of herpes. Her partner does not always use a condom when they have sex. She is initiated on acyclovir for this initial herpes simplex virus infection. Which statement is best to mention to DH regarding the treatment of her herpes infection? So option A is treatment of initial infection will decrease the risk of recurrent herpes. B is treatment will shorten the duration of symptoms and infectivity of the initial infection. Treatment of initial infection will decrease the severity of recurrent herpes infection. And treatment of initial infection will prevent the virus from remaining later in dorsal root ganglia. So in previous slide, we already discussed that treatment will not affect any risk of reoccurrence and severity of recurrent infection. So A and C is incorrect. And actually, virus will remain latent in dorsal root ganglia. So D is also incorrect. So B is best option, that treatment will shorten duration of symptoms and infectivity of initial infection. Okay, second case is DH returns to the clinic 10 months after her initial herpes infection. She is troubled by all recurrences and she is having 70 days. Which therapy is best to recommend? So within 1 year period, she has the recurrence of 7. And we discussed that if there are 6 or more within a year, we will go for daily suppressive therapy. So option will check valsaclovir 500 mg orally twice daily. Used for 5 days whenever she notices a recurrence beginning. So this is wrong. Acyclovir 400 orally 3 times daily to be used for 10 days whenever she notices a recurrence beginning. This is wrong because in daily suppressive therapy we can use regimen for twice daily or once daily. So D is also wrong. Then C and D include suppressive therapy option with famciclovir 3 times daily. Again, this is wrong. 3 times daily, no. Suppressive therapy with valsaclovir 500 mg daily orally is the best option for this condition when there are 7 recurrences within a year. Then Next infection is chlamydial infection, and symptoms include dysuria and penile discharge. There is less dysuria uh, in men when they have chlamydial infection than in gonococcal infection. And for women, usually they are asymptomatic, and this infection can lead to pelvic inflammatory disease and ectopic pregnancy and infertility. Management for chlamydial infection is azithromycin 1 gram in a single dose, or doxycycline 100 milligram twice daily for 7 days. Gonococcal infection have symptoms of penile discharge and dysuria. Women often asymptomatic, again can lead to pelvic inflammatory disease, and symptoms in women include vaginal discharge and dysuria also. So for gonococcal infection, treatment option is ceftriaxone 250 milligram IM plus treatment that covers chlamydia, that is azithromycin, if chlamydia is not ruled out. So when there is a gonococcal infection, we will use ceftriaxone and chlamydial infection. If you receive a question that there is no chlamydial infection or it's ruled out, then we can use alone uh, alone treatment of gonococcal, that is ceftriaxone. Six is pelvic inflammatory disease, and symptoms include lower abdominal tenderness, elevated erythrocyte sedimentation rate, elevated C-reactive protein. The sequence for pelvic inflammatory disease, the progression is abscesses in pelvic or fallopian tube, tubal occlusion, fibrosis, then cause infertility and ectopic pregnancies. Regimes include cefotecan, cefoxitin. Then there is another regime including clindamycin, gentamicin, and alternatively ampicillin sulbactam can be used in combination with doxycycline. Then IM treatment includes ceftriaxone and doxycycline with or without metronidazole. Then we have last sexually transmitted infection option is prostatitis. Symptoms include urethritis. There are two conditions: acute bacterial prostatitis and chronic bacterial prostatitis. If symptoms uh, stays even greater than 6 months, we will consider it as bacterial prostatitis. Therapy duration is important in prostatitis. It should be 14 days for acute, and it can go beyond 28 days, and we can uh, maybe longer, up to 6 weeks, and in some refractory cases can be more than 6 weeks, up to 12 weeks. So therapy choice depends on the organism. For ceftriaxone 250 milligram IM is usually used for gonorrheal infection, and fluoroquinolones like ciprofloxacin, levofloxacin, or ofloxacin, they are used for E. coli and Clostridium trachomatis infections. And then cotrimoxazole also, and trimethoprim and daily, also used for other than gonorrheal infections. Therapy duration for acute bacterial prostatitis is 14 to 28 days. We have discussed it earlier. For chronic bacterial prostatitis, their symptoms are more than 6 months. We use the treatment option based on the organism, and then duration will depend again on the duration will depend on the what he called it. Duration can be longer, up to 6 weeks, or uh, may reach to 12 weeks. So this was the last slide for this chapter, Men and Women Health. Thank you for your time. I hope this lecture will help you in preparation of BCPS. Good luck.